Hello, everyone, and welcome to the UHN Foundation COVID-19 Q&A live stream. I'm Christian Coté, host of the UHN podcast, Behind the Breakthrough, winner of the Outstanding Science Series at the Canadian Podcast Awards. We're glad you could join us and so grateful to you, our family of supporters who've been so generous throughout the past few years during the pandemic. So a big thank you on behalf of the UHN Foundation and all of Team UHN. We are approaching the 3-year anniversary of the pandemic due to the spread of the coronavirus, and it has been a long haul for everyone. So on today's broadcast, we will take some time to reflect on both learnings and surprises this once-in-a-century health crisis has thrown at us. We'll, of course, also look at today's state of living with the virus in Ontario, and we'll feature your questions a little later in the broadcast. Today, we're very pleased to be joined by Dr. Susy Hota, Medical Director of Infection Protection and Control at UHN. Welcome, Dr. Hota.
Hello, Christian. It's great to be here.
Let's start with Ontario and today. What's the dominant strain in the province? And can you talk to us about spread and severity of the virus?
Sure. So according to Public Health Ontario, they do genomic surveillance on a regular basis. The dominant strain of SARS-CoV-2, which is the virus that causes COVID-19, is the XBB.1.5, which is what many people call the Kraken subvariant. And it now constitutes just over 30% of our SARS-CoV-2 isolates. So what we know about this isolate, or this kind of subvariant, is that it's very transmissible. It's also very immune evasive, and more so than any other SARS-CoV-2 strain that we've seen before. What we haven't really heard of is whether it's behaving any differently clinically. So it doesn't seem to be more severe or causing more hospitalizations or deaths than any previous variant that we've seen.
And my understanding from reading at this point, 3 years in, is that the virus is now here. It will be a constant in our lives for a while to come, much like the flu. But on the plus side, we're reaching levels of immunity and protection that would appear to be limiting, the impact of the virus. So what I'm curious about then from your standpoint is, are these the conditions that might suggest we've entered an endemic phase of the virus?
Well, I think it's a good sign that we are seeing less fatality with COVID-19 infections. I think that's a function of, like you said, greater population immunity over time, also some changes in the characteristics of the virus strains that are circulating. But I don't think that we can necessarily say that we've reached endemicity yet. For that to happen, we need to see a little more stability in the patterns of COVID-19 transmission and a little less evolution of the virus. It's still, changing quite rapidly in front of us. So the virus isn't yet behaving predictably enough for us to say, yep, it's endemic. But what I can say is that we've reached a point where we're seeing less of the harmful impacts of the virus overall, even though it is continuing to transmit.
And you probably well know, a few weeks ago, there was speculation that the World Health Organization might remove the pandemic designation, but in the end, they decided COVID-19 was still considered, quote, a public health emergency of international concern. I'm sure, though, there are some people out there wondering, what's the point of maintaining the pandemic designation?
It's a great question. And you have to think of a pandemic as an international event. That's exactly what it is. The entire world is affected. And there are many countries that are still facing struggles with COVID-19, surges, impacts on people's health and mortality and complications that are significant enough. And like I said, the virus continues to change in front of us. And so we need to remain prepared for what could come next. When you continue to have a public health emergency of international concern, it keeps this at the forefront. So people are still having to do surveillance and monitoring of what's happening in their countries, reporting internationally so we can share that information. And I know there's some variability into the degree of that, but it's still more helpful than not having any requirement of that. But also they're expected to deploy more resources internally to managing it. And that could include things like making vaccines available and free for citizens so they can protect themselves, and therapeutics as well. So there are a lot of different implications to having that label that we may not see every day, but it actually really does help with the response to be maintained through these periods that, we're still somewhat vulnerable.
You mentioned surveillance, and which, of course, that's a great measure of knowing the severity of the virus. Certainly in Ontario, compared to, say, when we first started out 3 years ago, where we had like a daily measurement of the number of cases, and we still do measure hospitalizations, which are way down. What is the measures or surveillance that's out there now that's, say, as robust as what we had in the initial phase that could tell us exactly where we were at on a particular given day or hour?
There are a few measures that still remain helpful. One is looking at wastewater surveillance. And that data is more regional. It's not like you're going to get that for your city necessarily, but you'll get it for an area that you're living in. And what's most valuable is looking at the trend, really. So it tells you, are we going up? Are we going down? Where do we stand relative to, previous waves or interwave activity? Are we higher than usual? And if you look at that surveillance data, it really shows that we've been relatively stable, but kind of undulating, just waxing and waning a little bit off of what's a higher baseline than what we've previously seen, in between waves of activity of COVID-19. And that's really a function of Omicron and the variants that we're seeing. They're just so transmissible that we'll always have a higher baseline level of activity. So that's very useful. The other indicator we look at is of people coming forward to get tested. That's been a pretty stable number of individuals over time since we changed our testing criteria and kind of narrowed it down. But what percentage of them are actually coming back positive? We call that percent positivity for the test. And that, again, you can follow over time as a trend. And that tells you a little bit more about what's happening in the community. And you put that together with what's happening in hospitals, outbreaks that are also occurring. It gives you a bit of a story as to what's going on. And we may not have refined numbers for that story, but we do have an overall picture that you can, take from it.
I don't mean to put you on the spot, but do you think we might see that endemic stage this year?
It's hard to say. The years go by so quickly and the virus is, plodding ahead. It's possible that we'll be kind of transitioning into that, but I think it can take years to really feel comfortable with that designation. And I guess the worst thing we can do is take away, the resources to actually keep things at bay too quickly. And then drive a large wave of activity somewhere, internationally that ends up resulting in more mutations of the virus. And, you can actually end up kind of shooting yourself in the foot, I guess, by doing it too quickly.
Okay, well, let's look at some of the ways to continue practicing vigilance in terms of your own protection. What's your advice to people who have questions today, these days, after 3 years about protection as we go about our everyday lives? So that's like when you go to work, in the workplace, or when you're on transit or at a large public gathering. What's the current sort of advice that you give from an IPAT perspective?
A while back, we kind of shifted our approach to managing COVID-19 from a societal approach to more personal risk assessment. And we're still in that mode. That hasn't changed. And so, I think people have to make decisions based on, what their personal risk for getting COVID-19 and complications are. That has to do with, are you vaccinated? How recently were you vaccinated? Are you up to date with your booster shots? And have you had a recent infection that would also give you some immunity? Are you immune compromised, or do you have any other high risk conditions? But also, what other personal circumstances do you have? Do you live with vulnerable people? So you may be less vulnerable, but do you care for someone who is? Or do you have travels that are coming up that are really important to you that you need to get to, and you don't want to risk getting infected at that time? So other important events. And then where are you going and what are you going to be doing? Are you going to be in a closed environment that's small, where the risk of transmission is greater, especially if there are a lot of people in that area? Is it an older building? Those kinds of things. And then, of course, your comfort level. And putting all of those things together, it can help you to determine whether you want to attend something, if you are going to wear a mask while you're there. Are you going to try to distance from people? Are you going to, make decisions around eating or drinking there and removing your mask? Or, so it is quite granular and it's very personal at this point, but that's where we're at. And I think that's where we need to continue while we're still in this pandemic.
And the vaccine booster, what kind of protection are you seeing against this current strain, the XBB.1.5 strain of the virus today?
Well, it's a great question. And one of the problems is we're just not getting the data on the effectiveness of vaccines against different subvariants quickly enough. So by the time people start trying to do the studies to understand how well protected are you with our current bivalent boosters and, a primary series against the BA.5 variant, and then there is, the BQ.1.1. All of those have changed over by the time you start getting those studies going. So we don't know, is the bottom line, exactly how well protected you are against the current variant that's going around, the Kraken. But we can look at some of the more recent data, and there's clinical trials data that show that a booster dose with one of the bivalent mRNA COVID-19 vaccines definitely gives you higher neutralizing antibody responses. So your antibodies will be higher against Omicron sublineages, and that's different types of Omicrons that have been circulating, the earlier ones. But there's a little bit of conflicting information when you pull it all together. I think the bottom line is you'll get some protection against infection. It's not like it's zero. You will get some protection. It will wane over time. There is a little bit of data with the BA.1 and BA.2 subvariants of some of the older Omicron subvariants that your duration of protection against severe disease is maintained above 70% for at least 26 weeks after you've had an original non-bivalent COVID-19 vaccine. So if you look at that, at least that gives you some assurance that you're protected against severity of infection better still with these vaccines. So, I think that they still have value. They're not going to stop everyone from getting infected. They're not going to stop transmission on a broader scale, but they will provide some layers of protection that can be added to other things that you do to try and keep yourself from getting really sick from this virus.
And is there still a recommended interval time in between each booster?
So there are recommendations, but they are a little bit more complex now because we are dealing with boosters and multiple, iterations of boosters now. So the National Advisory Committee on Immunization in Canada, what we call NACI for short, is really the authoritative body that helps us to understand, what is the science telling us to do, but, also balancing that against equity and feasibility and other important factors when it comes to releasing a policy around vaccination. So I do tend to go to them as a go-to for recommendations. And they did release something in January. It's interim advice looking forward into 2023 on what we should be doing with these boosters. And it isn't definitive. It doesn't say we should all be getting booster doses of COVID vaccines every year or every 6 months or anything like that yet, although they're working towards that. So they acknowledge that we need to have something a little bit more stable. And that could be a recommendation that gives people an interval based on when their last dose was, or transitioning it into something like an annual influenza vaccination campaign where every fall you get, you go get your COVID booster and your flu shot. So they don't know yet which is the best way, but they did put out some words on, if you haven't had a booster, at least since that fall booster campaign, you may recall in the fall of 2022, they really were trying to promote people to get boosters. You should have one. And the greatest push is for those who are most vulnerable. So those over the age of 65, anyone who has a high risk condition where you might get very sick from it, you absolutely should have that booster within the past 6 months. And the other pieces of important information there are, if you're going to get a booster shot, you should get a bivalent. And either any of the bivalents that are available are considered, relatively similar in terms of how well they'll protect you. And they're likely better than the original at this stage. And then the other thing is, if you're going to get booster doses, you do need to separate them. So it's a little bit almost counterintuitive because we get worried about waning immunity and think, oh, geez, our immunity might be going down significantly after 4 months. And I should run out and get my booster for that reason. But actually, there's some data to suggest that if you wait a little bit longer between these doses, you get higher vaccine effectiveness. So at least 6 months between your last dose of vaccine or infection that you had, which also provides some protection. That's a recommendation for how frequently you should be getting these.
That's great. And is there a current status that you're aware of in terms of vaccine and booster uptake in Ontario? Like, are we where we should be?
No, we're not where we should be. It's a good question. I mean, as of the end of January, if you look at the sort of provincial data, it's under 23% of people over the age of 5 years who are 5 and up, who've actually completed a primary series and had a booster shot within the last 6 months. So it's not even just a matter of looking at the numbers of all people who've had these boosters. It's also about the timing, right? So given what we talked about with waning immunity and optimal immunization, It's about 23% of people who kind of fit within that, decent protection, I guess, within recommendations. And the proportion of people who have their primary series and received any booster in the last 6 months, it increases with age. So there's a difference whether you're older, and in the older age groups, we have much better uptake for these boosters. But in the younger age groups, it's quite low, especially in children. And understandably so, in that there is a lot more to consider with children, and the severity of illness tends to be lower in children with COVID-19. And so it is a bit of a decision that has to be weighed. But as of, again, the end of January, I think it was less than 5% of children under the age of 5 have even completed their primary series. So, there is a ways to go. I'd like to see us having a little bit more sort of equal distribution, but the other piece to take into consideration in interpreting that, answer to are we where we should be is how many people have had infections in that time. So we're not really looking at immunity from infections when we consider are we doing a good job just by looking at the vaccination numbers.
And so if someone does feel sick suspects that they might have COVID symptoms, how accurate are those rapid tests that you can take at home in terms of confirming if you're sick with COVID?
So the rapid tests are helpful. I just want to start off with that. I don't want it to sound like a negative thing when I say that there are challenges with it, but they definitely are helpful. They're kind of a great tool that empowers the individual to know what their status is. If you have symptoms and you test with one of these rapid tests, it may very well be negative for days. Until it becomes positive. And it's quite variable. So, one person might test positive after day 1 of illness, and another person in the family can be day 3 or 4. So the bottom line is if you're negative, don't exclude the possibility after 1 negative test or even 2 negative tests early on in your symptom onset. It might require a few days for you to come up positive. And if you're symptomatic and you're pretty sure you had COVID, especially if you had an exposure to someone with COVID-19 and the likelihood's high, then definitely stay at home and isolate. So that's the important thing to know about the test itself, but then also it's about the operator characteristics. So how well are you swabbing? So there's that to take into account as well.
And how long should we be isolating again now?
So there hasn't been a change in the recommendations. It's been like this for a while now. But ultimately in Ontario, if you've had COVID-19, you need to isolate until your symptoms have improved for at least 24 hours. That's 48 hours if you've had any gastrointestinal symptoms like diarrhea or vomiting. And you have to have no fever present for at least 24 hours. So that's really what happens with the general public. If you're in a hospital setting, you have different rules. So if you're hospitalized, or if you're in long-term care or in an institution that's considered sort of highest risk, you will be isolated for at least 10 days. And of course, making sure that you're improving. And if you work in those settings, you have to follow what the rules are for the institution. And then there is a bit of a caveat as well in that if you have immune compromise, and especially if you're in one of these higher risk settings, your isolation period can be much longer. It can be up to 20 days. If you're, in a hospital and you're immune compromised and you have COVID-19. So there are those sort of special situations where the isolation is still quite long. But for people out in the public, it is relatively short for most people. And some people who are asymptomatic, they don't have symptoms at all. You wouldn't need to isolate unless you develop symptoms. And then, of course, if you do, you follow that. You have to improve for 24 hours.
Certainly an incentive for protecting yourself from the virus is the risk of long COVID. Plus, I understand there's a growing body of evidence that reinfection, getting COVID more than once, can have serious consequences on our immune system. And it increases the risk of things like neurodegenerative diseases, cardiovascular problems. What can you tell us about the data there?
There are a lot of studies that are really aiming to try and characterize the risks of the longer term risks of COVID-19 infection out there. And there was an interesting cohort study that was published in Nature Medicine end of last year. What they were doing was comparing people with reinfections versus no reinfections or even no infections of COVID-19 and looking at some specific health outcomes. And so compared to no reinfection, those who had a reinfection, they had an additional risk of death that was, characterized by what we call a hazard ratio of 2.0 like over 2. So there was a higher risk of death and hospitalization, and also some other complications. And I think you mentioned a couple, but there's like lung complications, heart complications, even hematologic, so blood complications, risks of diabetes and kidney issues, mental health issues as well, and some neurological disorders, as you mentioned. And that risk in this study was evident, regardless of what the vaccination status was of these individuals. And it was most pronounced in the early stages, so the more acute phases of the infection, but it actually persisted even out to 6 months, that risk. And so, I think what that tells you is that there is an urgent need for better vaccines that will actually prevent these infections from occurring, not just protect us from the severe outcomes, to a certain degree. And so I think kind of looping back to one of the earlier parts of our conversation about public health emergencies and, what's the deal with that? Why would we want to do that? You also want to make sure that research and development is continuing in this realm, because we have a ways to go.
Yes. March 11th, 2023 will mark 3 years since the declaration of the pandemic. And what I found is one of the most staggering statistics is that over 50,000 Canadians have died of COVID in that time. And it's now the third leading cause of death in Canada, behind cancer and heart disease. Does that surprise you?
It doesn't, just because I've seen, the statistics. And I think we may have become a little bit desensitized to the effects of COVID over time, but it doesn't mean that it's become any less of a problem. Until the most recent waves in the later part of 2022, we were really always tracking above the expected mortality rate in the country. And there was a StatsCan report that was released again in January of this year. And the provisional data showed that there was an estimated 53,741 excess deaths. So I think, as you were kind of mentioning up there, in Canada from the end of March 2020 to the end of August 2022. And that's 7.6% more deaths than expected had there not been a pandemic. And the vast majority of those deaths in that period were attributed directly to COVID-19. And so, that's a pretty staggering statistic. And there's another thing that was in that report that caught my attention. It said in the third week of January of 2022, so that was right when Omicron arose and we first had that large wave, it was the deadliest week in Canada since the pandemic began. There were 27% more deaths than would have been expected at that time. And, I think we focus too on COVID-19 as being the main reason for all this. And certainly, like I said, the vast majority of these deaths were attributed directly to COVID infections, but there are also a number of other reasons for excess death that are associated with the pandemic, not necessarily COVID itself, but the pandemic. And they contributed, things like alcohol and drug and misuse and accidental overdoses. And so I think what it does is it shines a light on the importance of public health. And these crises just kind of open it up and make them more visible. But we have a number of different public health crises going on at the same time, and we really need to look at that differently now.
And 3 years ago, at the outset, I'm sure you knew better than most Canadians that the cascading effects that were likely to occur with the spread of the virus, the potential for it to overwhelm hospitals, the strain on supply chains and placing stresses on society that we were just ill-equipped to deal with. I'm curious, though, Dr. Hota, was there anything about how the virus has played out so far that has surprised you?
Not so much how the virus has played out, except like everyone else, I think the sheer exhaustion of this going on for 3 years plus, and continuing to go, and it always trying to change up the game. I don't think you can really plan for that. That's maybe not so much a surprise, but you just can't mentally plan for what that's going to be like. I guess what really took me a little more by surprise is I was aware that we would have to consider things like social media in how we responded to a pandemic and how a pandemic would unfold. And when we did pandemic preparedness before this COVID-19 pandemic, that was something that was, within the chapters of communications or something like this, right? But the actual effects of social media on the trajectory and how things have unfolded, the infighting, all the strange, bizarre things that emerged from there. That was a bit of an eye opener. And the conspiracy theories and the controversies, I guess I didn't expect quite the degree of it to occur and to continue throughout a pandemic. So those are, that's one kind of area. The other thing I'd say is, We always did the pandemic preparedness with the usual suspects in the room, right? It would be the infectious diseases person, the public health experts, the emergency preparedness, and, we'd have an ethicist there. But we didn't really think as much about the psychologists and the social scientists and some of the other, domains that are really, really important to include. We would have some of that, but it just probably wasn't emphasized enough. So those are the things that I would take away as, a bit of a surprise or things that became very apparent as we went through this.
Along that line, there's another learning that I wanted to get your take on, because my understanding is the issue of containment of a virus. My understanding is going into the pandemic, the WHO's recommended approaches or measures were things like hand washing, masking, physical distancing, but there was, and correct me if I'm wrong, but there really wasn't much mention of widespread lockdowns. And then COVID-19 kind of changed all that. So I'm wondering, first of all, did lockdowns succeed, first of all, in containing the impact of the virus and buy time for the hospital systems?
Yeah, I mean, it's a great question. And I don't think we have, there is still quite a bit of debate on that. Lockdowns or stay-at-home orders were always kind of in the array of public health measures that could be deployed to manage a pandemic. It wasn't something that just kind of came up in the midst of COVID-19. However, I don't think anyone likes or, relishes the idea of having to use that tool. In my opinion, we needed to do it. Whether we needed to put lockdowns in effect every single time we did and for as long as we did, I'm not sure. We'd have to analyze that a little bit more carefully, but it really did help the system to function in specific acute periods. It did help us because there's only so much we could do to distribute care across hospitals and work as a system and transfer patients and try to surge up. We really were at the point of having exhausted that. So we had to have some blunt instrument to help us reduce that transmission overall in the community that was driving all the entry into the hospital system. So from my perspective and from the perspective of that question of did it help to save the hospital system, absolutely. But it really does depend on your perspective to answer that question because overall persistent and prolonged lockdowns have a lot of other effects, right? They have effects on people's mental health, on the economy, on social structures, on, suicide and global health programs. Like a whole bunch of different things are affected by that. And so trying to tease out what the effects of lockdown are versus effects of the pandemic itself on these different factors is really, really hard. And depending on how you look at the data, you can kind of spin it either way. There was an interesting study or sort of looked at, I think it was a group that looked at what the effects were of lockdowns on excess deaths, because you can look at kind of the tip of the iceberg and say, did it have an effect? And, it did seem to imply that the countries that had lockdowns experienced fewer deaths from COVID-19. But, I think, like I said, looking at the greater picture, it's hard to know exactly what the value was overall of lockdowns.
So I guess the other side of the question was going to be, I'm wondering now if it's too early to even postulate whether when the WHO goes to rewrite its pandemic planning playbook, will lockdowns, do you think, become, I don't know if a staple is the right word, but do you think they'll become more of a consideration in future?
It's hard to say. I mean, I think that they should remain something that we can consider. But again, it'll take years to try and untangle what some of these impacts are and to understand how to maybe use them a little bit more judiciously. And again, it really depends on, will society actually accept that? So, it doesn't, in some ways, it doesn't even matter what the WHO puts in the playbook. It's whether or not it's actually going to be acceptable. And so, if we have another pandemic in 50 years from now, yeah, I think people would look at that and say, okay, how do they manage COVID? Let's look at the ways they did it. Look, this lockdown was what they needed to go to. And here's the data around it. If we have a pandemic in 5 years from now, I don't think most people would be accepting of a lockdown.
Interesting. The variability of the disease. I'm curious, the fact that some people could get COVID and really have minimal symptoms or sometimes none. to the other end of that spectrum where people have suffered really severe symptoms. And of course, it was dire in some cases. There was many people dying. Was that a surprise to you?
It's not really a surprise to me because, COVID's no different from other viral infections or other infections or actually diseases in general. And this is because, our symptoms are the consequence quite often of how our bodies respond to something. It's not even the pathogen itself, the virus itself, that's causing the symptoms in the majority of the time. It's about your body's response to that. So all of us are different, and some of us will have a very, very robust immune response to an infection, and that can actually lead to almost like it going overdone and critical illness related to that. And other people, the immune system's much quieter in terms of how it sort of manifests that response. So I think there are a lot of factors that influence whether people have no symptoms, minimal symptoms, moderate, the worst. It has to do with, like I said, the body. It also has to do with how much of the virus you're exposed to in a lot of situations, what we call the infectious dose, how well your immune system actually operates or works, functions at that time. Do you have other health conditions that might put you at risk for, pulmonary disease or lung complications? Were you vaccinated? How long ago were you vaccinated? So when you put it all together, it's no surprise that, your infection might look different from mine.
And the variability of the number of strains of the virus, I'm curious, because I understand we're up to like hundreds now. This instability in this constant mutating of the virus, is that a surprise?
I guess in a way it really is. I expected some evolution of the virus for sure, but not having really experienced this before, at least not in this way, I just didn't expect that we have so many subvariants to deal with. And especially since in the earlier stages of the pandemic, we had sort of the original one that lingered around for a while, it seemed. And then we had Alpha come up, and everyone was like, "Oh my gosh, it's big! This variant. We should be afraid of this variant." And then it seemed like there was a little more time between the variants. Alpha, the Beta, and the Gamma didn't really go very far, and then Delta. It was Omicron. Omicron came and changed everything. It took it to a different level. And since Omicron, we've seen so many different sublineages of it that are co-circulating. It's gotten to the point where, you almost want to stop paying attention to what's happening with the variants and the subvariants and the sub-variants. And, it's a lot of background noise. And really, to me, it comes down to the three main questions. Is what's going around more virulent? So is it more severe, causing more severe illness? Is it more immune evasive? In other words, is it going to escape our immune response from a natural infection so you can get reinfected frequently, or the vaccine's going to be less effective to protect us? Is it more transmissible? So that's going to drive more transmission and overall impacts related to that, like hospitalizations just by sheer numbers. And I guess the fourth question is it resistant to any of the therapeutics that we have? And right now we really just kind of have Paxlovid and not a lot in our armamentarium to try and treat this, but that would be a relevant question to ask as well. And just kind of looking at those, I perk up when I hear about something that sounds a little bit more ominous on that front. But otherwise, there is a lot of instability, a lot of mutating of these viruses. And at this point, we just can't manage them differently. It's not like we have different protocols for how we manage them in the hospital or anywhere else. So it just is a part of the landscape.
And I know in your role, you're so immersed in the daily monitoring of this and protection in terms of our patients and staff, et cetera. But I'm curious, have you had any time to reflect then on the impact or, the fact that this coronavirus mutated and changed, the number of strains that came along so fast? Is there some sort of implication for the future in terms of this virus?
The implications for the future are if it doesn't slow down and it continues this way, it's going to be very difficult to get to those stability conditions we talked about earlier to call the pandemic over, right? It's going to continue to threaten various parts of the world or cause, impacts that are hard to ignore. And of course, we have to worry about if that, perfect triangulation actually occurs and you get the mutations that will make it a stronger, more virulent, more contagious, more resistant type of virus, then we can be in for a real problem. And I worry about that because of the vulnerabilities of our system, even coming out of the last 3 years. So there are a lot of things that kind of go around in my mind for the future. I'd like to be optimistic. Maybe I'm being too optimistic about it, but I feel optimistic about it in that it feels like we should be able to hopefully be on the tail end of this pandemic, and things will start to evolve into something more stable. I feel like that's the most likely scenario. But there's always in the back of your mind that possibility if we let things rip and it's completely unmitigated transmission worldwide, then you can get that triangulation, and it just has to happen once. So that's kind of what goes through my head in terms of implications of the future. Is I really want that steady state.
You mentioned a few minutes ago, but you were a bit surprised that sort of the height or the heightened misinformation out there during COVID, and it had real life consequences. Promoting quackery like hydroxychloroquine and ivermectin as methods of protecting against the virus. Is there anything that you think can be done to help people understand or how to cut through that misinformation in future?
Yeah, I mean, how do you cut through misinformation? I mean, my instinct is to say shut down the internet, but we wouldn't be able to have sessions like this, which are actually informative and helpful, I'd like to think. No, I mean, we need to have some regulation of the information that goes up, especially on high traffic sites, ensuring that the media also is doing a great job of vetting the information that comes to them, and we have credible people speaking on it, and we're looking at the science and not at postulation. I mean, these are some ways we can try to protect, but also I think increasing society's health literacy in general will help. And that's a big task, especially since education has also been impacted by lockdowns and this pandemic and such. But we do need to make it a priority because some of the things that have come up, honestly, like, I expected some snake oil to rise, but, drinking bleach, volcanic ash, 5G bioshields, there are all kinds of strange things that came up on the internet. And it's just amazing what people will do when they're feeling desperate, and they can try these dangerous things.
All the more important too, I guess, in terms of like you were mentioning also earlier, continuing sort of funding and profile for pandemic planning and protection. Like we've heard rumblings in the past few weeks of an avian flu called H5N1 being a potential threat. So you'd think the need for pandemic prevention and preparedness would be firmly embedded in our psyche and also in health and political circles. I'm just curious your take. Like, will it continue, do you think, to get the funding and profile it currently has?
Oh, I certainly hope so, because you're absolutely right. It really does feel like in the last 2 years, the number of sort of emerging infectious diseases or unusual trends in infectious diseases or new things, it seems to have accelerated, which is, like almost shocking in some ways, because we did have lockdowns and things like that, which you'd think would reduce kind of the transmission of infections. But no, I think it's the rebound effects and the fact that we just live differently on this world now with animals and other creatures, and those risks of, infections jumping from different animals into humans, it's ever present. So I think we absolutely need to continue to lobby for public health funding, for emergency preparedness for infectious diseases, as being something that we don't just think of as a niche or a specialty thing. It has to be really ingrained in what we do. It has to be something we prioritize as a society. We have to keep track of what's going on. And so I do think that's what we need to do. Whether it's going to happen, people are also quite fatigued and tired this, and so we're in this weird spot where society's more aware of the potential hazards that are out there and communicable diseases, but everyone wants more than ever to just close their ears and eyes and run away from it. So how that plays out politically is not really clear to me.
Well, we'll do our best, certainly at UHN, to keep promoting the fact that this is crucial to and intertwined with our health. We could keep going on. I have tons of questions I'd love to ask you, but I do want to bring in the audience because I know we have a number of questions lined up from all our people out there listening today. So let's go to our Slido and let's throw these at you. Quickly to all of you out in the audience, we'll get around to hopefully all the questions, but just to bear with us given our time. So first question for you, Dr. Hota, what is the best approach going forward to stay protected from severe symptoms due to COVID-19?
Yeah, I mean, I think this comes back to what I said a little bit earlier. It's an individual-based approach, and so vaccination is still important. That's actually why we're seeing, one of the big reasons why we're seeing fewer deaths and hospitalizations overall, given the proportion of cases that are out there. So, trying to stay on top of the vaccinations recommendations of NACI would be really helpful. Using masks as required. So, depending on your age, so older age groups, just by virtue of age, are at greater risk for more severe outcomes. But if you're also immune compromised or vulnerable because of other health conditions, if you're in settings where you feel you might be around a lot of people and there's a lot of COVID circulating at that time, then masks are useful protection that you can add to, all of the things that you would do. Avoiding settings that really are not going to be comfortable for you because of, again, lots of people crowded in the same place, poor ventilation, things like that. That would be another strategy. So it hasn't really changed a whole lot. It's just a little bit harder now, I think, because everyone else is kind of trying to live more freely and like before. But it does come down to you making those decisions.
Next question. I heard that if we received the bivalent vaccine, we don't need to get another unless COVID mutates again. Is this true? And there also doesn't seem to be as much pressure to get updated at the 6-month mark anymore.
Yeah, so there's nothing that says that you shouldn't get another vaccine. I think, like I had indicated earlier, it's just not clear exactly what to do after you've had that. So the strong recommendation is, especially if you're over 65 or you're, at risk, you need to have a bivalent booster, preferably, at least since the fall. So, and that's an important thing to stick to. And then beyond that, we haven't established whether it's every 6 months or if it could be a little longer than that before you would get additional doses. And right now, the bivalent boosters, as I've mentioned, are the preferable option compared to the original one. But again, it also depends on if you get an infection in there. So, there's a lot to factor in there. I think what we have to do is wait to see what the more definitive recommendation is from NACI.
A question from JJ. Mainstream media is not regularly reporting on COVID cases. This helps reinforce most people's belief that COVID is now over. Where can we get regular updates on COVID cases, hospitalizations, and deaths in local communities, Ontario, Canada, and around the globe?
So Public Health Ontario has a lot of great epidemiologic reports that they put out. They're not put out on a daily basis or in real time like before, but you can still get useful information off that website. There's also wastewater surveillance data that's available there. So that is a good source for Ontario. Within Canada, there's also data that's reported up. So all of the jurisdictions are still reporting up to Public Health Agency of Canada, and you can search for that and find it off the Government of Canada website.
From Greg, what COVID-19 mitigation measures can immune suppressed or compromised people take when traveling by air, and how effective are those measures?
So again, this comes down to vaccination, wearing a well-fitted, well-designed mask during the times where you're going to be in close contact with others, and only taking it off when you need to eat or drink. Washing your hands because surfaces can get contaminated. It's less of an important mode of transmission, but it's still something that you can do. Where it's possible, keeping distance from people, but quite often that's not possible during air travel. So, those are kind of the mainstays of what you would do. And of course, if everyone was able to stay at home or was following the stay at home when ill, that would definitely help the situation.
From Jill, the widespread condition named long COVID by rough math based on stats thrown out by media. If 70% of us have had COVID and 20% of them suffer long COVID, that's a potential 5 million citizens. Public health has ignored what can be a life-altering disability. What steps should be taken?
This is long COVID's a very important aspect that we talk about, but we don't talk enough about. And part of it is we don't know enough about it yet and what it's going to take to support people through the longer term complications that they may or may not face from COVID. And some of them are not as easy to pick out until a little bit later. So I guess I'm kind of saying, yes, I agree. This is something that's really important, and we need to continue to try and understand it better and make sure that we have the right health system structurally and functionally to support all the different things that might come out as a consequence of COVID infections, cardiac, diabetes, whatever it may be, the mental health issues, the neurological issues. So there's investing in health that way, also investing in vaccine development still. So, I think there's some sentiment that nobody's paying attention anymore. We absolutely need to continue looking for better vaccines.
Absolutely. I see people coming into coffee shops with their mask on. They unmask, sit with their coffee, etc., for an hour without their mask, and then out it on to go out into the street. Is there any value to that?
Yeah, I mean, when you're outdoors, you're definitely safer, and you wouldn't need to mask really, compared to indoors where you're, in a shared space with other individuals. So it does seem a little counterintuitive here to do it this way. I don't think there's a lot of value in doing that. To be honest, if you're going to be masking, it's really when you're in indoor settings that it would make sense to do that around other people.
From Lilac, what does receiving COVID boosters for the immune suppressed community look like moving forward?
Yeah, unfortunately, again, I can't answer that because we haven't figured out what that frequency would be. But what I can say is, like other vaccines, influenza, others, those who are immune suppressed will be the priority for any kind of vaccination. So I guess what I can say is recommendations will always be more heavily slanted towards those who are immune suppressed really should be trying to follow this as best as possible. So you'll always be in a priority group for that for the reason that your immune system can't fight off this infection as well, and you're more at risk for severe infections.
From Melody, she says, I'm 70. My next COVID vaccine is due in May. Should I forego it until the fall as COVID appears to subside in the summer?
Again, I think we'll hear from NACI probably relatively soon because there are a lot of people sort of itching to get that information of what the frequency would need to be for ongoing booster shots. And it may not be 6 months. It may be that the determination is an annual vaccine is better. So I would hold off and wait and not worry too much about it. Come May, if they haven't released anything yet, you can probably wait a little bit longer, and then just follow what NACI's recommendation is.
How long after contacting COVID will it register on the tests that we can do at home? We were talking about that earlier.
We were talking about it earlier, and it's very variable. So I've heard lots of anecdotes on this, and it can be 4 or 5 days in some cases, or it can be right away. So it's very, very variable.
What's the effectiveness of Paxlovid?
So Paxlovid is really kind of our only therapeutic at this time. The clinical trials that helped to get it authorized were done in people who were unvaccinated. And so the effectiveness in reducing the risk of hospitalization, preventing hospitalization and death was something like 89%. It was quite high. So it was a dramatic effect in that population. Now we have some more real life experience that includes people who are vaccinated and unvaccinated. And a study that was published not that long ago in the US showed 51% reduction in risk for severe outcomes in those who had Paxlovid compared to those who didn't, both unvaccinated, vaccinated, and those who had previous infections. So it is potentially helpful. One of the challenges is accessing it in time because you've got to have it within 5 days of your symptom onset, ideally, for it to work. And then some of the other things about, who qualifies for it, and the risks of drug interactions and things like that.
Mm-hmm. Will doctors, nurses, and hospital staff be wearing masks forever going forward? Will this become a standard when we enter hospital or a doctor's office?
Yeah, I'm not really sure where we're going to end up with masking. I mean, I think there's a lot of desire to move away from universal masking the way we've been doing it in hospitals. And I think there's some logical steps that can be done. But, it may very well be that depending on how COVID and other viruses are behaving for the next several years, masks will be around at least during respiratory virus seasons or something like that. So there may be some flexibility in how it's going to be used as a tool. But, we definitely did find it protective and helpful in the hospital environment to protect our patients and our staff from one another in terms of transmission of respiratory viruses. So, it may end up being something that we see seasonally for a longer period of time, or might become the new norm. But yeah, we're looking at that even right now. Just what will look like.
And I was just going to add an addendum to that people should keep in mind that at UHN, we often are actually treating some of the sickest of the sick who are, immune compromised, transplant patients, that sort of thing. So that's also part of the measures why we take those measures. And I know your office just revised our measures yesterday, but the masking in place still remains.
Yes.
Is it still recommended to disinfect surfaces at home to kill any COVID-19 droplets? Also, is it possible to contract COVID-19 from eating contaminated food, i.e. if someone diagnosed with the virus sneezes, coughs on the food while preparing it?
So surface-related transmission of COVID-19, we call it sort of fomites. That is a possibility. It's just a much less likely way of getting infected than through breathing air of somebody who's infected and nearby. So yes, it is important to clean surfaces in general, but I guess going out of your way to disinfect surfaces or wipe down groceries and things like that are not worth your while. What's probably more important is washing your hands before you eat or drink, which will protect you not just from COVID, but many other things as well. And in terms of the contaminated food, yes, that can happen. It would be, again, less likely, and it would require the COVID virus, the virus that causes COVID, to actually get into your airways somehow from having eaten the food, which happens. We cough up stuff sometimes and, like swallow and choke a little bit. Or if it's on your hands from having handled the contaminated food and then you touch your nose, eyes, mouth, yes, that could happen. So it's one of the reasons why we've had some limitations on sharing food and things like that through this pandemic. So it is, like I said, a much less likely way of getting it, but it is something that could happen.
What qualifies as long COVID, and how do we know if we have it?
So there's still a little bit of debate on this, and the definition varies quite a bit from study to study. But if you have symptoms that linger more than 3 weeks after your COVID infection, then that could be long COVID. But it really does require a proper assessment, clinically, to understand what the symptoms are, why you may have them. There could be a number of it could be a red herring. Let's say that. So I guess the best thing that I can say about how would we know if you have it is seeing your health practitioner, and if there is question about it, being referred to a clinic that kind of specializes in this. And I think increasingly we're seeing people who've become more sort of familiar with long COVID, and trying to see somebody who actually has that experience will be very helpful.
From Courtney, how likely is it once you've had COVID with no long COVID symptoms to contract long COVID with a subsequent illness?
It's a great question. I don't have the stats in front of me, and I feel like there has been a little bit of research trying to understand what your risk is of long COVID after having had subsequent infections, because it's very easy for people to think, oh, I got COVID last year. It was fine. I didn't have any problems, so I'll be fine again this time because this is the way my body reacts to it. But I don't think that's necessarily the case. I think that your infections can look a little bit differently each time that you have them, based upon all the things we talked about earlier, right? What strain it is that infected you each time, how much of it were you exposed to, how did your body react to it at that time? So I guess the important message is if you've had COVID once, it doesn't mean that you're exempt, and you didn't have longer term symptoms, it doesn't mean you're exempt from that happening in the future. But how that plays out and what that risk is exactly is not 100% clear to me.
Question from Deborah. Are we factoring in the impact of long COVID in our capacity planning for healthcare in the future? It has had a serious impact on young people who will drive healthcare utilization in the future.
Yeah, this is something that I think I kind of implied a little bit, that we need to think about this in our planning for the system in the future. And, what the resource needs are, where they're best placed. In other words, primary care, public health, hospital system, other ambulatory type settings that we are imagining, all of that needs to be considered. Like where are we best putting these resources? But also I do think that, it speaks to an area we fail in quite a bit, which is prevention. So trying to think of how we can actually help prevent some of the furthering of the impact of these consequences of COVID-19 infection by getting ahead of it before people need to utilize sort of the parts of the system that are really constrained right now. So there's a lot of work that needs to be done. Some of it's happening, absolutely. This is a time when we're kind of looking at the healthcare system in general and trying to make it more efficient and higher quality for people, our citizens anyways. This is all part of that story.
And sidebar, UHN certainly on the research side is driving that with Drs. Angela Chung and Margaret Herridge. And on the clinic side, we have certainly well-known clinics over at Toronto Rehab and Toronto General. All right, last question for you, Dr. Hota. Many people are hesitant to make appointments to see a family doctor or go to hospital because they feel the staff has been through so much and are struggling to continue working. How should we deal with this feeling of not wanting to burden our healthcare staff and yet keep on top of an illness?
That's a really interesting question. So what I will say is, first of all, thank you for thinking about your healthcare practitioners and thinking about the stress of it. It has been very stressful, and family doctors and other primary care practitioners absolutely have felt a lot of it. If you arrive with a smile and you come proactive about wanting to, be on top of your health, that will go a long way, because that's what your doctor wants. Your family physician wants to see you, really trying to do what you can to address the problems before they get worse. And they'll appreciate that. But, showing that empathy for what they're going through will probably go a long way. So don't feel like you're burdening anyone or the system. Do what you need to do to get the right healthcare. And that's what we're here for. But just, be mindful, like we all should be, about supporting one another.
And being kind.
Yeah.
We've come to the end of our time. That was fast. To all of you out there watching, thank you for joining us. And to our guest, Dr. Susy Hota, Medical Director of Infection Protection and Control at UHN. So appreciate you taking the time out of your busy day to be with us today to share your insights and expertise. This live stream is available for viewing on the UHN Foundation Facebook and YouTube page. As soon as we're done here today, you can take a look at it or share with your friends. And finally, donor support. Your donor dollars fuel the groundbreaking research initiatives of our award-winning UHN scientists who are working to discover new treatments and cures for patients. It's pioneering work, it's pioneering work that Newsweek magazine actually used to rate Toronto General Hospital as the 4th best hospital in the world. So if you're able to give, we ask you to consider making a donation. Go to www.uhnfoundation.ca/help. Thanks everyone for tuning in. We'll be back soon with another episode. Keep an eye on your email inbox. In the meantime, stay safe, take care of each other, and have a great day.